everyone, and welcome to another episode of our podcast series. I'm Hetvi Shah, your host, and today we're diving into a topic of great importance in maternal and fetal health, which is gestational diabetes, a condition that affects significant number of pregnancy worldwide and has implications for both mother and the child. Joining us today is Dr. Peerzada Ovasis Ahmad, an esteemed endocrinologist with extensive expertise in diabetes management, particularly in gestational diabetes and pediatric endocrinology. Doctor has a wealth of clinical and research experience, having made valuable contributions in understanding young onset diabetes patterns all over India. He's also pioneering collaborative work on diabetes management with Professor Bruce King from John Hunter Children's Hospital in Australia. His commitment to improving diabetes care is evident in his recent initiation of the Life for a Child program in Srinagar in India. So, Doctor, thank you for being with us today.
Thank you so much for giving me opportunity for this important podcast.
Thank you, Doctor. And we are so eager to hear your insights on this topic. Now, so Doctor, to start with, can you briefly explain what exactly gestational diabetes is and how it differs from type 1 and type 2 diabetes? And what are the key risk factors for developing gestational diabetes? And are there any specific populations that are more at risk for developing the gestational diabetes?
All right. So gestational diabetes mellitus, or GDM, it's a type of diabetes that specifically happens to women while they are pregnant. So gestational diabetes, as per, if I try to define it or explain it into simple terms. So diabetes detected first time during pregnancy in a woman who was previously not known to have diabetes and which is not overt. This can happen at any gestational age, but specifically happens during second or third trimester of the pregnancy. Now, how it is different from the other two types of diabetes, that is type 1. So type 1 diabetes is a little rare form of diabetes. It usually happens in children and young adults. It happens due to an autoimmune process where the autoantibodies attack the pancreatic beta cells. They destroy the beta cells, and beta cells make insulin. There is no insulin, and people get diabetes. So this is type 1. Whereas type 2 diabetes, this is the most common type of diabetes. When we talk about diabetes, we often mean type 2 diabetes. So it happens to people who are obese or overweight. The pathophysiology behind it is insulin resistance and also insulin deficiency. So these are the types of, this is how gestational diabetes differs from type 1 and type 2. Now, what are the risk factors for gestational diabetes? Now, women who have a strong family history of diabetes, either in one parent or in both parents, women who have a history or have polycystic ovarian syndrome, women who have advanced maternal age more than 35 years of age, are women who have a previous history of gestational diabetes, women who are obese or overweight, and certain ethnic populations, even Southeast Asian population is also high risk. So these are the risk factors for gestational diabetes.
So there are like different risk factors affecting the gestational diabetes when it comes into consideration. So now, moving on to diagnosis. So what are the most effective diagnostic tools for identifying gestational diabetes? And are there any advancements in early detection that, clinicians should be aware of?
So the gold standard for diagnosing gestational diabetes is performing a test called as OGTT, oral glucose tolerance test. This is usually done in the second trimester, starting from 24th to 28th week of pregnancy, where a woman takes 75 grams of glucose mixed in 1 glass of water. Then blood samples are drawn, first during fasting before taking the glucose, then after 1 hour and 2 hours. And the diagnostic cutoff, if a fasting blood sugar, that is the 0 hour sample, exceeds 92 or more, or if you do a 1 hour post-glucose test, which if it is 180 or more, or 2-hour blood glucose test if it is 153 or more. Out of these three, if one is abnormal, this is considered as gestational diabetes mellitus. Whereas the advances is concerned, there are researches going on where they look at inflammatory markers during the early pregnancy, but they are not diagnostic and they are not still used as a diagnostic protocol. Though if women are having those risk factors that I mentioned, overweight, obesity, polycystic ovarian syndrome, history of gestational diabetes, you should screen those women even before 24 weeks. In fact, during the first antenatal visit, you should, it's for the gynecologist that most of these women would go to a gynecologist. They should consider screening for gestational diabetes even in the first trimester itself.
So that was so fascinating to know, especially with so many advancements. And can I was just curious that do you find that early detection significantly changes the trajectory of gestational diabetes outcomes, which is like compared to something like a standard screening time or something like that?
Of course. See, first of all, it's very important to understand that why we need to detect diabetes early and why we need to treat it. So, if you are experienced with high blood sugar during the first trimester, starting from sixth week onwards, where the organogenesis takes place, if you are exposed to high sugars, it can impact the fetal development. The woman is at a risk of developing some congenital anomalies like anencephaly, microcephaly. It can cause some congenital cardiac defects like atrial septal defect. So there are so many complications related to congenital abnormality related to diabetes. Therefore, it's very important that if we pick the diabetes early and we give an appropriate management, then they would have an uneventful pregnancy. There will not be any complications either to mother or to the fetus.
Yes, that is so rightly mentioned. Now, speaking of the outcomes itself, so can you talk about the short-term and long-term health implications of gestational diabetes on both the mother as well as the fetus?
Yes. So, as far as the short complications in mother is concerned, a mother can get preeclampsia, type of high blood pressure. You can get cesarean section. You can have some birth related complications. Then in fetus, a fetus can have macrosomia. The size of the fetus would be more. The baby weight would be more. They can have neonatal hypoglycemia. They can have a neonatal hyperbilirubinemia, or they can even have fetal demise. And I have seen a lot of women who were not detected with gestational diabetes had ninth month intrauterine death. So this is the short-term complications. Whereas the long-term complication in mother, they may get a lifelong risk of type 2 diabetes. They can get diabetes during second pregnancy as well, and they have a almost 50 to 60% risk of getting type 2 diabetes in next 10 years postpartum. Whereas the fetal is concerned, I told you about the short-term complications of fetus, while as the long-term complication when the baby is born, which is exposed to mother who had high blood sugar, can have childhood obesity, can have type 2 diabetes in future, can have high blood pressure, can have so many other complications of metabolic syndrome.
So the impact is such, high impact for both the mother as well as the child, I would
As well as
say.
the fetus.
Yeah. And then I was just curious that what are the chances of these risks? Like, are they like 50 to 60%, or are they even higher than that?
So it depends. Like, suppose someone who has a condition called as pre-gestational diabetes, who's already diabetic and gets pregnant. So it is very important to keep a optimum glycemic control. So women who are planning for pregnancy and are diabetic, and they should keep their HbA1c below 6.5%. If you conceive at a higher HbA1c, the more the HbA1c, the higher are these risks. So risks are still there even if you control, but if you have an optimum control, you start a good diabetes control, then the risk is less.
Yeah, so that actually makes a lot of sense. So different risk factors again play an important role. So now on the topic of intervention, so could you explain how insulin therapy is tailored for pregnant women with gestational diabetes, and at what point insulin is typically introduced?
So before I talk about the insulin therapy, let me describe about the complete management. Like if a woman who is referred to us by a gynecologist with a deranged OGTT. So what we first do is we do not immediately start insulin. We start on a diet plan which is called as MNT, medical nutrition therapy. So where we give them a diet chart depending on the weight of the pregnant lady, gestational age of the pregnant lady. So we tell them to take less refined carbohydrates. So the total intake of carbohydrates should not be more than 40 to 50% of total calories. And those carbohydrates should come from the complex carbohydrates. And we put them on the lifestyle modification, that is exercise. So we need to have a target. Like once you are detected with gestational diabetes, the target, the glycemic target should be fasting blood sugar should be below 95 milligrams per DL throughout the pregnancy. And if you do a 2-hour post-meal sugar, it should be kept below 140. That should be the target. Or if you do a 2 hours blood sugar test, it should be kept below 120. So once we start the women on medical nutrition therapy, we give them a couple of weeks and they monitor their blood sugars. If they do not achieve the glycemic targets on the diet and exercise, then depending on which sugar is coming high, for example, if only the fasting blood sugar is coming high, then we start them on a basal insulin, which would be a detamir, or it could be an conventional NPH, that is the insulin N, or we can even give them some ultra long acting insulins like degludec. Whereas if their postprandial blood sugar is coming above the target, then depending on which blood sugar is coming high, we can start with insulin. So insulin, we can give them regular short-acting insulin. We can give them fast-acting insulin analogs like Lisipro or Aspart. And insulin is only given if the MNT fails and exercise fails. Then we start insulin. So insulin is usually given. Multiple times a day to have a very strict control, because as I said, in gestational diabetes, you need to have a very strict glycemic control. You need to keep your fasting blood sugar below 95 and postprandial 2 hours below 120.
So a lot of care has to be taken during this time. So additionally,
Yes.
how do oral hypoglycemic agents fit into the treatment plans for gestational diabetes?
Yes. So the first line of management is insulin. Even the ADA recommends that the first line of management in gestational diabetes is insulin. We do not have a lot of options to give oral drugs, although tablet called metformin and glyburide can be given. In fact, metformin can be safely given. So sometimes we also, if a woman is very obese and we suspect that she has a very severe insulin resistance, we often give metformin. Although both metformin and glyburide do cross placenta. So in my clinical practice, my first line would be insulin, sometimes with or without oral metformin. Glyburide, practically, in practical terms, we do not give glyburide. I don't know anyone who gives glyburide. So oral drugs have limited role. The mainstay of treatment for gestational diabetes is insulin.
Yes, I think that approach is quite individualized also sometimes. Now, gestational diabetes often brings risks for type 2 diabetes. You also mentioned that earlier. So, could you tell us more about how having gestational diabetes actually affects a woman's risk for profile, not only for type 2 diabetes, but also for future pregnancies?
See, as I previously said, that women who get gestational diabetes, out of them, 85% soon after delivery, the diabetes goes away. Up to 10 to 15% of women, the type 2 diabetes may persist. I mean, the diabetes may persist into type 2 diabetes. Therefore, it is very important after the delivery, it is recommended that women who got gestational diabetes should again get screened for type 2 diabetes after 8 to 12 weeks of postpartum after delivery. so that we should not miss their type 2 diabetes. And if you get diabetes, as you know, diabetes is related to a lot of complications. You can get a kidney complication related to diabetes. You can get a heart complication related to diabetes. You can get blindness. Leading cause of blindness is diabetes. And in the second pregnancy, like if they remain diabetic and if they conceive on a very high HbA1c with high blood sugar levels, then the risk of those complications that I mentioned are more. So it is very important that we should give them education as soon as they give delivery. We should give them education on lifestyle. If they are overweight, we should encourage them that they should lose weight. They should involve in regular physical activity. They should change their diet, and they should adapt healthy lifestyle. They should restrict themselves for taking high carb diet and high fat diet, and they should keep their weight under check. This will help them in preventing the other complications of gestational diabetes and cholesterol.
So yeah, I was just mentioning that actually prevention and follow-up seems to play such a
Very
pivotal
important.
role here.
Yes.
And yeah, so I'd also be interested to know your approach. So do you find that a structured follow-up plan post-pregnancy helps in significantly reducing these future risks?
Yes, definitely. Like if we get a woman very early, like if she has been screened at the right time, then it's very easy for us to manage her. Like we always, start her on, explaining why she got diabetes. It's very important for a person to understand that why she got affected with this gestational diabetes. And then also we have to give a lot of reassurance that if we treat it well, then she will have an uneventful pregnancy, because most of the times they come in a lot of anxiety and stress when they come to know that they have diabetes, and they are very curious and very concerned about their baby. So my approach always is spending a lot of time in explaining them. Like ideally, you need a multidisciplinary approach. You need to have a qualified dietitian. You need to have a diabetes educator, and of course the endocrinologist and the diabetologist, which will make the treatment. So most of the times I do all these things, because we do not have a diabetes educator with us. So we explain them that which food is going to largely impact their blood sugars, and what are the replacement options that they have if they stop this type of a food, which food they can take. And most important, which I forgot to mention, is that blood sugar monitoring. It's very, very important. It's not just about giving insulin or metformin or lifestyle modification. You need to plot this blood sugar results on a log, what we call SMBG, self-monitoring of blood sugars. That is how we'll know what is happening with this patient. So they need to plot it. They need to regularly check their blood sugars. And in some of the women, we also advise using a device called CGM, continuous blood glucose monitors. So yes, the approach is always structured, and we call them for the follow-up after every 15 days or after every 1 month till they reach to their delivery time. So if we get them at the early time, always the outcome is better. But if we get at a time which is already, like somebody gets a gestational diabetes at 9th month, detected at 9th month, where an ultrasoundologist or a radiologist was performing ultrasonography, and suddenly he found the Liker is high, and he found that she has polyhydramnios, and then you do a OGTT test and come to know, oh, this is over diabetes now. I think that is late. So our approach is finding the appropriate risk factors, screening them early is very, very important, and then management is very easy.
Yeah, that is like actually a good structured plan will always help, as you mentioned. And and sometimes even the pregnant women gets very tense. So communicating with them also becomes very difficult.
It's very, very important. Yes.
So thank you so much, doctor. And this has been a deeply enlightening session. So thank you so much for sharing your expertise with us today.
Most welcome. And thank you very much for giving me your time. And I'm really happy that I spoke on a very important topic. And I'm looking forward that in future also we can have some more topics. We can discuss about some more topics. Thank you very much.
Definitely, we would love hearing your more insights on such different topics as well. So, thank you so much. And to our listeners, we hope today's episode gave you valuable insights into managing gestational diabetes with the latest approaches and strategies. And remember, if you're a healthcare professional who's eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, take care and stay healthy.